after kidney transplantation can be donor-derived, recurrent, or de novo. To understand the impact of glomerular disease recurrence on allograft outcomes, to recognize that glomerular disease after transplantation can present without the classic features of microscopic hematuria or proteinuria, and then to understand that the time to recurrence varies between different glomerular diseases. And some of these points will illustrate through review cases of glomerular disease recurrence and treatment. So we're going to get started. So I'm going to do just a few intro slides about sort of major concepts, and then we're going to actually explore them further through some cases. So just so that we're all on the same page in terms of the terminology, when we think about glomerular diseases after kidney transplantation, they can really only be sort of from three different quote unquote sources. They can either be donor derived, they can be recurrent, or they can be de novo. And what donor derived glomerular disease means is that the donor who gave the kidney to the recipient themselves had a glomerular disease, and so that the kidney in the recipient has a glomerular disease, but actually is unrelated to any pathology in the recipient themselves. And so that's what we're going to term donor derived. In terms of other kinds of glomerular diseases, so if the donor did not have any glomerular disease, but they gave their kidney to a person who's had who themselves either did or did not have glomerular diseases, if the patient themselves had, for example, let's say membranous nephropathy pre-transplant, and then they develop again the same membranous nephropathy after transplant, we're going to refer to that as recurrent glomerular disease because it's the same disease the recipient had before and after the transplant. Let's say if the patient had uh, a non-glomerular disease, let's say they had diabetes or had a glomerular disease such as IgA, but then developed a different glomerular disease after transplant, such as membranous, for example, since that new glomerular disease is different from what they had pre-transplant, we're going to refer that as de novo glomerular disease. So I just want us to keep this terminology of donor-derived, recurrent, and de novo in mind as we approach cases going forward. And some historical perspective, because I think it's really nice to like think about where all this came from. So the first kidney transplant was done at the Brigham and Women's Hospital here in Boston, and in the first case series of glomerular diseases of kidney transplant here, they actually recognized that glomerular disease can recur like very early on. And this is a paper from the 1960s by Dr. Richard Glassick, who we all know very well, which looked at the first 22 transplants done between identical donors. This was between 1954 and 1965, and GN was the original diagnosis in these patients in 17 of the 22 involved. And in these patients, they actually recognized that about two-thirds of them developed recurrence after transplantation. So this is a problem that's been recognized, for 50, 60 years now. And so, it was really cool to find Dr. Glassick's paper from so long ago. So, why is this important? So, this is important for a few reasons. The first reason is that glomerular disease recurrence is actually pretty common after kidney transplantation. Um, and if you look at some of the older data, there's a lot of registry studies earlier on, and then more recently, like better designed retrospective cohort studies. But basically, glomerular disease recurrence is actually pretty common after kidney transplantation. And here, just as an example, I'm showing data from the Australia and New Zealand data registry, looking at the recurrence of a few glomerular diseases. And basically, what I'm just trying to illustrate is that the recurrence is actually pretty common and occurs at different rates depending on the glomerular disease. And we're going to go into more details about that in a little bit. But perhaps more importantly than just it being common, there's clear evidence that the glomerular disease recurrence is associated with a higher risk of kidney allograft loss. And so, as you can see here, in people who've had glomerular diseases in part of this, in this registry data, people who developed recurrent glomerular diseases had a several-fold higher risk of losing the graft. And so, not only is it a common problem, but it affects graft outcomes, and that's why we should care about it. And then we'll go through this through the cases, but the other concept to think about when we're thinking about glomerular diseases that recur after transplant is sort of the timing of recurrence, because different ones have different sort of recurrence timelines. So, for example, atypical HUS and primary or idiopathic FSGS tend to recur very early after transplant. Things like membranous nephropathy recur typically in years 1, 2, or 3, and then things like IgA tend to recur a lot later. Um, and so basically, just again, as we approach this, the concept is recurrence of different diseases has different flavors, especially in terms of the timeline. Great. So now let's jump to the cases because I think they will nicely illustrate some of these points. So let's start with case one. And some of these cases were cases that have been published in the literature, in which case I'd have like referenced the specific case, and some of them are from my personal experience, but I've modified some of the features to protect the patient's identity. So for case one, this is a case that was published about 10 years ago. This is a 61-year-old man with a history of type 2 diabetes, and this was complicated by ischemic cardiomyopathy, advanced systolic heart failure, and CKD4 with an eGFR of 28. He developed CKD after like a severe